Good morning to everybody. My name is Melanie Wiedmeyer. Thank you all for joining us this morning to hear what Dr. Craig Emmitt Cole has to say about multiple myeloma. Dr. Cole is with he's board certified in oncology and hematology, and he is currently working for Carmanos out of Lansing and also is assistant professor at the Michigan State University. We welcome you today, Dr. Cole. I muted you, so I'll have to have you unmute yourself. And if you wouldn't mind taking a minute to tell everybody what you're currently working on. I know you've done a lot of clinical research as well. And two, I want to thank everyone for coming, but also remind you of our upcoming events as well. We have our next Ask the Doctor events are on the screen. You can register for those at our website at curemultiplemyeloma.org. Also, we have our Wine and Dine in the D event on November 6th. Keep that on the radar, and when registration opens for that, we hope to see you there. And then I'll turn it over to Dr. Cole. I'm sorry, this is a big one. Thank you to all of our sponsors that helps bring us here to you today. And when we do our in-person events, they help a lot with that. And some of them are on the call today as well. So thank you for your support. Without you, we wouldn't be here. And also thank you to Sid Moss, who is our founder of the Cure Multiple Myeloma Corporation. And is through his efforts that we are here today too, to bring this to our community here in Metro Detroit. So thanks so much. Dr. Cole, I'll turn it over to you.
Oh, great. No, thanks for the introduction and hi everybody. Um, it's good to see everyone. A lot of familiar faces and names on the list. And I guess yeah, I'm my current, you know, in the I'm currently at Michigan State University doing myeloma. I'll be in June. I'll be also doing myeloma at Hermanos downtown in Detroit, and so I'll have two clinics running. My main clinic will be in Detroit, and I'll have my outreach clinic still in Lansing with the patients that I have there and the clinical trials that we have there. And I guess the big thing that we've been working on in tandem is looking at some of the biology of smoldering myeloma, which is a project we've been working on at Michigan State for quite some time. Um, we're opening a couple, in fact, later today, we have a couple meetings on clinical trials that we're opening using trispecific antibodies and that we're really excited about that have longer half-lives, actually less cytokine release syndrome than what the current available bispecific antibodies have. And then I do a lot with health equity. That a lot of these, as I think everyone knows, a lot of these myeloma drugs are super expensive, and they're not, and somewhat because of logistics, i.e., what happens with the CAR T and the expense of some of the other therapies and the bispecifics, that not everyone has access to these novel therapies and these fantastic therapies that we have in myeloma. And so a lot of work that I do is trying to figure out how we can make care more equitable in the United States. There are huge areas in the United States, in the Southeast and out West, where there's hundreds and hundreds of miles away from places that can deliver CAR T, clinical trials, or bispecific antibodies. So there are people dying with this disease in areas where there's no therapy. There's nobody there to care for them. And so, I think a big challenge is, the only way we can cure myeloma is to cure it for everybody. And the dual challenge that we have in doing research with this disease is not only to figure out a way to make, to cure myeloma and to make the disease, more controllable for everyone across disease states, but also across, ethnic, racial, and especially socioeconomic states. So that's me in a bit of a nutshell.
Thank you. We do have a question from Jerry. What can you tell us about PEMGARDA and
Yep.
when will it be available and who will be eligible?
So you may remember Shield a couple years ago for COVID, and it was for people that are immunocompromised, and people that were unable to have adequate responses to the vaccinations for COVID. The Shield, kind of the built-in when the FDA, gave it conditional approval. Shield was built into that approval was that if it was ineffective against 10%, which I thought was a kind of a small number, but 10% of the current COVID strain at that time, which was the Omicron variant, that it would be pulled off the shelf and not be available. And actually that happened, what, in 2022, 2023, when the East Coast began to see the XBB1, I think it was called, um, variant became dominant in the East Coast, and then automatically Shield was pulled off the shelf when that variant, it hit well over 10%. It was more like 90%. And then it went across the country, and basically Shield was ineffective. And so then we were kind of, and so it was automatically pulled, and then we were kind of left with, really vaccinations. And so recently, another company has a PEMGARDA, which is a similar antibody, except it's an infusion that's given over an hour. So you may remember Shield was a couple shots, and this is actually an infusion. And the um, and it is basically based on the same approval that Shield was for people who are immunocompromised, who are unable to, or on immunocompromising medications, who are unable to have an adequate response to the vaccinations. And so that just happened, I think, a couple weeks ago when the conditional approval for that drug came out. And so now it really is, waiting for it to actually be released. And so everything I've read says in the next couple weeks. That was a couple weeks ago. And I asked our pharmacy about, when are we going to have that available? And they said that probably in the next couple weeks. So I think when the FDA says it's going to be 2 weeks, I think you have to add on, 2 weeks to the 2 weeks and make it more like 4 to 5 weeks. But I think that for, patients who are definitely stem cell transplant, in the myeloma realm, there hasn't been there hasn't been formal recommendations specifically about myeloma patients yet. But I suspect that especially people who are status post stem cell transplant should definitely get it. Patients who are on active therapy for relapsed or induction therapies for myeloma should definitely get it. The big question is going to be, people who are on long-term maintenance there. Oh, I'm sorry, and patients who had CAR T therapy, or I would even say definitely bispecific therapy should definitely get it, because especially, the BCMA CAR Ts and the BCMA bispecifics are very immunosuppressive. And so my plan is that, newly diagnosed patients as who I'd give it to, patients who are on active therapy relapse myeloma, I would definitely give it to. Anyone that is on a bispecific, we can talk about it later. The infectious risk for the GPRC5s aren't as high as they are with the BCMA CAR Ts. And so, and definitely the infectious risk is much higher. I would say reasonably higher with the BCMA bispecifics. And so I would definitely give it to someone who's on a BCMA bispecific. And I guess one thing we have to kind of figure is what to do with people who are in maintenance therapy. Maintenance therapy isn't, depending on the maintenance regimen that someone's on, it's not that immunosuppressive. Um, and in the studies show that people who are in, very good partial responses and in complete responses, have pretty good responses to the vaccinations. And so I think that we're going to have to, and one thing that I haven't seen is there haven't been any updates on how well we had a lot of things going on regarding, vaccination responses with patients who have myeloma with the, Omicron and some of the other, more lethal variants. Um, I haven't seen very much at the meetings regarding how well, are the lesser, toxic variants of COVID are responding to, people who are immunosuppressed that are getting vaccinations. And so I think that, I would, wait a bit to see what we're going to do with people with maintenance therapy. Does that answer the question? I hope.
I think it was a great answer. Very thorough. Our next question comes from Mary. When do we think the tri-specific antibodies may be ready for prime time availability for patients?
Yeah, that's a really good question. So, of course, they're all good questions. Um, so they're currently in clinical trials, and there's like three variants of the tri-specific antibodies. So, the bispecific antibodies are, two-pronged. One part of the antibody sticks to T cells and usually CD3 T cells, and the other one sticks to either BCMA, which is on myeloma cells, or GPRC5, which is on myeloma cells. Um, so that's teclistamab and talquetamab and Elran are the three currently approved prime time bispecific antibodies. The two flavors of tri-specific antibodies are one is when it has one that's for T cells, one for myeloma cells, which is BCMA, and a third, which is to albumin. And what the albumin, and you would say, what does albumin have to do with with myeloma? And what albumin has to do with myeloma is that it prolongs the half-life of the drug. And so when you have a trispecific antibody, it actually stays in circulation longer and still has the BCMA, still gets the T cell, but it lasts longer in the body. So you don't have to get as many infusions because right now, Talc, Alran, and Tech are like weekly or bi-weekly, and the trispecific antibodies have albumin. People can get once a month, which would be a big time bonus. And those are in current they're in current randomized phase 3 trials. And so people are really excited that that may be coming out, pretty soon. I think there are a couple different variants for that. And that's the clinical trial that we're going to have at MSU. Um, the other was really exciting. Still in very early clinical trials, super early clinical trials, is the trispecific antibody. I can't help but smile. that is a BCMA, so it goes to myeloma cells because BCMA, goes to T cells, and it goes against GPRC5. And so, so it hits, it hits the myeloma cell on two different fronts, instead of just one front. And you say, well, what does it matter? Well, the problem with people relapsing off the bispecific antibodies and CAR T is that one of the two, so when you give, teclistamab or LRAN against BCMA over and over and over and over, the BCMA, receptor, if it has just a little mutation on it, then the BCMA doesn't work anymore. That the bispecific antibody doesn't attach to the myeloma cell. So if you have two, if you have three going on, then you hit the myeloma cell. It's very difficult for the myeloma cells to escape if you're hitting it from, two different sides with the trispecific antibody. And so that came out at ASH, this past ASH, in December, and everyone was just like, and they were kind of funny because they were like, they showed the slides and everyone's like, oh, there's going to be clinical data. There's going to be clinical data. And so, the place was packed and everyone was like excited. And then they're like, we're just going to show that we're going to start running the clinical trial. And we don't have a lot of data yet. But the really cool thing is that there was a study that was the redirect study that was at ASCO last year, where patients got both a BCMA and a GPRC5 at the same time. So they got talc and tech at the same time, and the response rates were just off the charts. I mean, they actually were superior to a lot of the CAR Ts. And so but it's a pain in the butt to have to get, LRAN or tech and talquetamab at the same time. And so if you could combine that in one drug, that would be a game changer.
Awesome. Awesome. So our next question comes from Terry, who loves your background, loves the Star Wars in the background. And she's asking, with CAR T hopefully coming up in earlier lines, if you are high risk and harvested your cells, but have achieved MRD6 after first induction, would you see CAR T as a reasonable line before SCT?
Wow. Yeah, in fact, there's a patient that we have I talked to yesterday that we were talking this about. And every Friday, um, all of us, all the myeloma doctors in the Kamano system, gonna get together and we have a tumor board we also discuss. And that's really gonna be the big question. You know, is A, will we need to be doing stem cell transplant, as salvage, as condition, as a consolidation therapy. And maybe we should repeat, use CAR T as that consolidation therapy. And to really push people in deep responses. And I think the big difference is between stem cell transplant and using CAR T. One is that, when you get CAR T, there's no maintenance therapy. It's a one and done issue. And so, with stem cell transplant, we're doing, as everyone knows, we're doing maintenance therapy, because just doing, some sort of what we used to do back in the early 2000s. Oh, and well before that was just, no one got maintenance therapy. People would relapse after a couple of years and we would move on. And maintenance therapy really changed the game after stem cell transplant. But, now having CAR T there and seeing that even in super bad myeloma that people don't need maintenance therapy, that's going to be I think a big game changer. And so, should we be doing, CAR T, and getting those super deep responses, MRD responses, instead of stem cell transplant, and leaving the stem cell transplant for a rainy day, I think is not an unreasonable, option. The one little caveat, the one little thing that, everyone, including me, are super excited about the FDA advisory board, basically approving, not the FDA proper, but the advisory board approving using cilta-cel and really CAR T as, as second line therapy, and is that the one thing that gave the FDA pause, the FDA advisory committee pause, was that, with Carter 2, 4, which was, CAR T for early relapse myeloma, CAR T versus standard of care, that there was a higher mortality rate with the patients on the CAR T therapy. And there's a lot of hemming and hawing about, well, does that higher mortality rate worth the, super long, progression-free survivals that were happening with CAR T? And they kind of came down and saying, well, the progression-free survival outweighs the risk of death on the car with the CAR T. But they said, really, you guys need to figure out why people died, why there was an increased numbers of deaths on the CAR T. The mortality with stem cell transplant is less than 1%. The mortality with CAR T is higher. And so it'll be really interesting to see, how, I give you that in first relapse, that, with that higher, the progression-free survival, I think is outweighs the risk of having, especially in people with early, relapses, the outweighs the risk, the mortality risk associated with it. But when you start to move it up even further, and you put a comparative CAR T versus stem cell transplant, I think that, unless they can really figure out what that mortality business was about, which I think is maybe infection, and until we get really, and we're evolving to make CAR T safer and safer. I think that the FDA soon may take pause with the increased mortality rate. I think overall we'll have it figured out how to make CAR T safer, which would then have it as a replacement for stem cell transplant, and we can use a stem cell transplant at a later date. I hope that answered the question.
I think it does. I think it might have even answered a question from Steve. And Steve, if you have a follow-up question, please let us know. Let's move on to Linda's question, and she's asking, are there any clinical trials for maintenance therapy after ASCT that would be better than Dara or Rev with PT with one
Um,
gain?
I that's they're all good questions, but it's kind of a timely question because there's a fight going on. There's a Twitter fight going on right now, that I have put myself in the fray of, that was asking this very, very question is, what it was, I'll tell you, it was kind of a mess. Somebody asked basically the same question, that they, a myeloma doc. So there's a myeloma Twitter group that's all over the world. Um, and people, people publish opinions and papers, and it's really kind of a fun group. The kind of funny thing was someone asked basically the same question. It says, well, what do people do with, 1Q gain for maintenance therapy? And it was kind of all over the place, which, the official official guideline. So I won't say official, but a guideline that people look at. Two guidelines people look at. One is the M-Smart from Mayo Clinic, and which has been around for years and years and years. And the other, which is new and up and coming, is Memorial Sloan Kettering guidelines. Both those guidelines say for people who are high risk, particularly 1Q gain, should receive REV and a proteasome inhibitor as a dual maintenance therapy. So, and that's kind of my jam, because I've seen the studies, I give you some of the studies date back, are really old studies, but when you kind of mash all the studies together, you see that that the dual maintenance works well. When more recently there have been studies looking at maintenance therapy that didn't do that, where they considered, the stamina study, which randomized patients between newly diagnosed patients, status post-transplant, randomized between a second transplant, consolidation followed by rev maintenance versus rev maintenance. And that study showed early on that the high-risk patients did perfectly fine with rev maintenance. Later on, they said, well, the people who got 2 transplants did better, and that with high-risk disease. And it's like, no one wants 2 transplants. And that study really should have included an arm that said to do, rev maintenance, or a dual drug maintenance. And so and that kind of told me, gosh, maybe that is doing the right thing, that having dual maintenance is kind of the right thing. Um, the people at Emory, they give carfilzomib and Rev as maintenance therapy. Um, and other people said, well, I just do Rev maintenance therapy for 1. And then someone else said they give Rev maintenance for a year, then they stop. And I was like, what? That is totally not the standard of care. But I didn't, I don't want to get in a fight with anyone on Twitter because it just gets ugly. So what that told us is that people are kind of all over the place regarding this issue. And there is currently I think one of the most important trials we have in myeloma in the modern era right now is the SWOG study 1803, which is really going to answer this question. It's really going to answer it, I hope. And the way that study works is that you can get whatever you want for induction therapy. In these days, it's all quad therapy. DARA, RVD. After transplant, there's a randomization to Rev maintenance alone versus DARA Rev maintenance. So do you need a 2-drug therapy, or can you get by with a 1-drug therapy as maintenance therapy for all comers? Then there's a second randomization that happens, that if you're after 2 years, if you're MRD negative, then you can you get randomized to opting out of maintenance therapy versus staying on whatever maintenance therapy you're on. And so that study is going to tell us 2 things. Is one, for high-risk patients, do you need 2 drugs or not? And I think that in the modern era, with DARA RVD being the induction therapy, do you really need, a dual induction therapy? The second thing is, can we really, use MRD as a measurement for patients in the United States getting intensive induction therapy? Are we able to get by with stopping maintenance therapy if someone's MRD negative? And we don't know the answer to that either. And I think the only way to answer your question is really a randomized trial. I think that, the reason that people are all over the place regarding this is that they're basing this on phase 2 trials, on personal experience, on institutional guidelines, and not based on modern and me, what do I base my therapy? What is MSMART and what does Memorial base their guidelines on? They base their guidelines on old trials that predate, DARA RVD. And so we need, a modern trial looking at modern questions using modern technology like MRD measurements to be able to tell what's going on. But that's the big trial that I think is going on.
Mary's asking if you could explain the 1Q gain high risk.
Oh, Lordy. That is, it, yes, I can't because we don't know, but I can do my best. Um, so, um, so chroma, this is really interesting because for years and years, my gig when I was a fellow was fish. And when I went to Dana-Farber, I walked in there with all my fish stuff, and I'm like, this is going to be the way that we figure out how to risk stratify myeloma. Back in in 2000, 2001. And so, and then, we came up with the current, risk stratification for myeloma between the standard 414 deletion 17 14 16 14 20 as being high risk, and underneath, and actually from Japan, interesting enough, they were doing larger span, not just looking at the classic quote unquote high risk features, but they were looking at other cytogenetic abnormalities. And underneath everything, there was this chromosome 1 abnormalities, and specifically gain of chromosome 1. And at the time, gains of chromosomes were always seen as something good to have when you have myeloma. So if you had, a trisomy, if you had 3 chromosomes of 5, you had 3 chromosomes of 7, if you had 3 chromosomes of chromosome 17, were all seen as good things. And so when people saw, 3 copies of chromosome 1, we were all like, that's good. But the Japanese said, no, that's not, that's not good. And they had proof of it. And then as more and more studies were done, people were seeing that additions of chromosome 1, and this was back in maybe 2016, 2017, were considered intermediate risk. And as we looked at it further, we then saw that it was actually a high risk feature. And there are gradations for that. So if you have 3 copies of chromosome, you're supposed to have 2 copies of chromosome 1. If you have 3 copies of chromosome 1, then that means that you have a gain of function. So, if you have 2 copies, one from mom, one from dad, then it's pretty much normal. If you have 3 copies, then you have a gain of whatever's on that chromosome. And if you have 4 copies, then you have really a gain. And you would say, well, what does it matter if you have a gain of function? Well, there's a lot packed into chromosome 1. There's a lot that's packed into that. And some of the things that are packed into that are things that help myeloma cells proliferate. And so there are cell cyclin genes that tell the cell to proliferate quickly. And you can imagine if you have 3 copies of saying grow quickly, the myeloma is going to go faster. And if you have 4 copies, it's going to grow really fast because then you have a gain of function. There's also the receptor for IL-6 on chromosome 1. IL-6 is the main receptor for myeloma cells that help them proliferate, stay alive, and be resistant to chemotherapy and dexamethasone. So you can imagine if you have more copies of of the IL-6 receptor, it's going to make the cells especially, anti-apoptotic, especially proliferative, and is especially able to survive in the bone marrow microenvironment. And there are a number of other genes that are pro-myeloma that are packed into chromosome 1, which makes that gain of function then kind of a bad thing. Um, and then the big question, and it is the most common high risk cytogenetic abnormality in myeloma. It can occur at any time when people have myeloma. So these days, when we do when someone relapses, we have a tendency to check their cytogenetics on another bone marrow biopsy. And especially, we're super happy that we have a CD38 selection for our fish. So we're able to get a really high fidelity reading on the fish cytogenetics to be able to tell, what's going on with somebody's cytogenetics. And so, and now there are studies that are looking at, so cell cyclin is also overexpressed in breast cancer, is overexpressed in other cancers. And so there are also studies that have been going on trying to target cell cyclin. And I don't know how well it hasn't been working so well for myeloma because it's just not the cell cyclin genes that are involved in the risk of chromosome 1. But like I said, there's a lot of other things packed in there that sort of drive the disease on chromosome 1. Hope that answers it.
Thank you. So Terry has she says she's going through all this in New York, where she has choices for specialists and she's financially sound. She can't imagine going through this in a more remote place, or, with less resources. So how can we, the patients, help the patients you spoke of earlier when you talked about disparities?
Yeah, so thanks for asking that. You know, um, it's a really good question. The I guess there are a couple things. One thing is to try is to try to be visible with this disease. What I mean by that is by being on forums like this and being on other forums and really talking to other myeloma patients. Because one thing I think that we looked at during studies that we did during the patient experience surveys that we did with the cancer support community and Gilda's Club was how isolating myeloma can be. And if someone has melanoma, then it's pretty easy. It's pretty easy to, yeah, I mean, just like Hal did. I mean, you can point to your ear and say that's melanoma, and everybody knows what melanoma is. And you don't have to even unmute yourself to explain what melanoma is. Myeloma, to explain that you have myeloma is a challenge because you have to have a certain degree of medical savviness to explain what the immune system is, what a plasma cell is, what plasma cell function is, what M protein is. And so it takes a lot. And the person you're talking to also has to be medically savvy in order to understand what you're even saying. And so you can't point to you can't point to your ear and say myeloma. I mean, you have to go through a whole process. And that, can be very isolating. And just imagine, just like you said, being in, the American Southwest, in Nevada, where there's only, one place in the whole state that's doing myeloma clinical trials. And imagine being, in Mississippi, where, or in the thumb of Michigan, I think is like the place I always worry about, where where you just where you're very isolated with it. And so saying that you have myeloma, helps other people. I always worry about the a patient that's going to church in the thumb who has this disease, who can't tell people at her church that she has it. But if we are, bring this disease to the forefront, she can at least think, gosh, there are other people out there that are like me, and if you talk to people with this disease, every time I always hear that as soon as someone's diagnosed, they hear other people who are diagnosed. They like, everyone was saying, yes, I know about this disease. And it shouldn't be that way. It shouldn't be that when you say I have myeloma, everybody else says, oh yeah, I know about that. It should be people should, and because it means that people are keeping this close to their vest, and the only time that they'll admit that they know anybody about it is when someone says the word myeloma. It should be way, way more out there. And to tell patients, that have this disease, here are some of the new things that are happening. Come to some of these meetings and hear about all the excitement and all the new things that are happening. We'll give those people hope, and we'll give those people the opportunity to do things like get telehealth second opinions, that we can help their doctors in remote areas be able to treat myeloma. And I'll just give a quick example. I did a telehealth with a patient in Honolulu, Hawaii. And so I did the telehealth, and he was newly diagnosed, now a year ago, a little over a year ago. And I put in my note to his hemonc doctor in Hawaii, that RVD, is the new induction regimen. They have been giving only RVD, and RVD has been, in my opinion, standard of care for at least a couple years. They were still giving RVD to patients in Hawaii. So he read my note and he's like, oh my goodness, I need to start treating everybody. And I put in my note, this is why the randomized trial, Perseus and Griffin, shows that this is the standard of care. So then they changed their whole practice based on a telehealth. And that's how, so in a remote area that was getting care that wasn't just up to date, that doctors are well intended, but just wasn't up to date. One telehealth changed an entire practice. And I think us being out there and saying, getting second opinions that you can get a second opinion from your living room, and about myeloma can really be a game changer in remote areas to alleviate some of those disparities.
Great. That's great. So next question, what blood test is done to measure your coagulation potential? Is it called coagulation index? And the question is related to taking Eliquis.
So it's a very good question. So there is a risk stratification algorithm that when someone is newly diagnosed with myeloma, and and there is a clotting risk associated with taking Revlimid as newly diagnosed myeloma, there is an algorithm, a risk stratification that can tell you which anticoagulant to use. Mostly it's aspirin for patients, but also some patients that have higher risk may need Eliquis or one of the other blood thinners. And so and that is based on ethnicity. People of Asian descent have less risk of getting clots with Revlimid than Caucasians and Black people. It's based on family history, personal history, ability to mold, if you have lots of bone fractures with myeloma when you're diagnosed, that's a risk factor. And so you put all those things in the algorithm, and then it gives you, which one to pick. And so it's not really one specific blood test, but more of an algorithm that we use.
Great. Linda Leck is asking, does a 35-year-old patient need to stay on maintenance therapy of DARA and REV for the rest of their lives after ASCT with the 1Q gain?
Super, super good question. Um, so, so the unsatisfying question is, well, we can see what the 1803 trial shows. I hate that I hate that answer. Um, and rest of your lives is a tough thing to say. So I would say that, would you be on Dara Rev for at least 2 to 3 years? Yes. Would I say that Rev until the time of relapse? If nothing changed in 2020, as of 2024, if the research engine shut down cold, then it would be, DARA for 2 years, and then Rev maintenance indefinitely. The fact of the matter is that there are multiple studies. So we had, as soon as we found out Rev maintenance, had a overall survival advantage and a progression-free survival advantage, we flipped the script and we put everybody on maintenance therapy. And we said we're going to leave it on forever for everybody because it's so much better than the way things were. And only now are people beginning to really say who really needs to be on maintenance therapy. I mean, only in the past like 3 years, people are really examining maintenance therapy because because I think there are probably people who who do need to be on dual maintenance indefinitely. There are people who are probably people who don't need to be on any maintenance therapy at all. When I dial back the Wayback Machine to like 2002, 2003, when we didn't do maintenance therapy, did everybody relapse after a couple of years? A lot of people did. Did everybody relapse? No. We have people who continued after stem cell transplant for very long periods of time before we gave maintenance therapy. So and I think everybody knows myeloma is more like multiple myelomas, that everybody has a different disease. Everyone's a little bit different. And so to shoehorn and say, well, everybody needs to be on the same maintenance therapy for forever means that we're undertreating some and overtreating some too. And just now there are clinical trials, because really you would say, why now? Because we have the technology to be able to tell who should be on maintenance therapy and who's not. We have now better fish studies. We have molecular studies for myeloma. We have, and especially MRD is the big thing that has really been the game changer. And I think once we get MRD out of doing bone marrow biopsies and into doing blood-based MRD, which is coming up, then that'll totally change the game of we can do MRD instead of doing these SPAPs and these free light chain measurements, we can do MRD testing, circulating DNA testing for myeloma that will help us tell who's MRD positive, who's MRD negative without doing bone marrow biopsies. And we can have people stay off maintenance therapy who don't need to be on it, and people who do need to be on it, should or needs more therapy, we can then escalate up, not based on just shoehorning everyone, but individualizing therapy. So I would say, rest of your lives, that's a long time. And things will change within your lifetime that will help guide us in a better answer to that question.
Great. Mary has another question. She's just hearing that one of our health systems is bringing on a hematology and oncology to the myeloma clinic that has been specializing in other cancers besides multiple myeloma. How long do you think it may take this person to get up to speed with the field of multiple myeloma since it's so complex? I'm sure that they will be under the auspice of other multiple myeloma experts, but still worried. Also, how hard is it to recruit good multiple myeloma specialists to a health system?
Wowzers. Um, I guess it depends on, so, you know, so how hard is it to recruit myeloma specialists in the health system? Um, so I guess the one answer, so how long does it take to get up to speed? Depends on how, um, depends on how interested that person is in getting up to speed, basically. I mean, I go to Ash, and when I go to Ash, I only stick with, I just do myeloma. And when I go to IMS, the International Myeloma Society meeting, that's 100%. That's like that is diving to the deep end of the pool for myeloma. And you can get up to speed pretty quick, you know, if you really, really, dive into the deep end of the pool. And especially because there's so many new things happening in myeloma that it's a good time to jump in because it's all new. I mean, so many things are new. There's not a lot of old things that we have going, and the old things we have going on, we're getting rid of. Um, you know, uh, uh, well, it is hard to recruit people into myeloma. And the reason is that there's so many other competing cancers. Myeloma is on, this steep incline. And we were doing really well because we were on a steep incline, and all the other cancers are sitting there just like, still giving chemo. Now everyone's on a steep incline. And so, recruiting into myeloma has become way more competitive because, what used to be, kind of the pit of cancer, like lung cancer, no one wanted to go into lung cancer because there's no treatments and it was lethal. Now everyone's excited about lung cancer because, they're winning too, and other cancers are winning. And so it's become a bit more difficult to recruit into myeloma. But we definitely, work at it. But, I think that it does take time, and but I think it's a really exciting time. My funny thing, when I was at Ash, I walked into a meeting room and it was half full. And I was like, what? Okay. I was like, and I sat down and I thought I had the right meeting room. Um, and I'm sitting there and I'm like, myeloma conferences are never half full. They're never half full. And I was like, something's wrong because it's never like this. And there were a lot of older doctors in the audience. I was like, what is this? So someone puts up a slide and it's diffuse large B cell lymphoma. So I like got my stuff, ran out the door. I'm like, I can't be in this room. So I went over to the myeloma, I was in the wrong wing of the hotel. So I walked to the other side of the hotel, got there soon, and I walked in, and the myeloma room is packed, standing room only. And I think I've said this before that I walk in and I'm looking for a seat because they're all full, and everyone's got hair, and people are wearing t-shirts, and I'm like, the lymphoma, meeting had a bunch of, doctors my age, and older. I go into the myeloma room and there's young people there, and how you cure a cancer isn't with a bunch of old doctors. It's with people in t-shirts wearing jeans and sandals, that cure a disease because they have a fresh perspective. And that's what's really exciting. You know, if you ask me pound for pound, what's the most exciting thing is that consistently we have, you know, lots of people, you know, that are on board, that are working at this disease. And I would say, hands down, more than any other you know, I go to ASH, I go to, you know, some of you know, I go to the myeloma meetings. I look in at some of the other meetings, and their meetings are always half full, and the myeloma meetings are packed. There was one meeting I went into, and I couldn't even get in because it was, and they had to close it. I'm like, I'm here early, and they had to close it. I stood in this long line, and then in order to get in to hear about daratumumab. Actually, it was the CD38 antibody. So it was with ixekizumab and daratumumab. And I'm like, this is insane, but a good insane that people are so invested in this disease. And that's that's the game changer.
So our last question is to follow up. This is to follow up the question that she heard that from a patient. She's heard from a patient perspective that this person is an awesome person that will be great bedside manner and very caring. So she's not worried about this new person at the clinic she spoke of before. And then lastly, she asked, are people of color being more actively recruited as residents and young doctors to help minimize the health disparities from the top down to patients?
Yes. And we're working pretty hard at that. So I'm working with the IMF, International Myeloma Foundation, the MMRF, are both in that field. I say the IMF has been working with with a lot of student organizations in medical school to recruit myeloma doctors in. And one thing that I was a part of is a student mentorship program, where the IMF pays for a student to be mentored by a myeloma doc. So I was in it, and Dr. Zonder at Carmanos downtown, we were both mentors to students of color, to recruit them into myeloma. And my student actually is very interested in myeloma, and hopefully he'll go into it. I almost lost him to his surgery rotation, but I pulled him back in. And so we have a couple of projects that are going on, and that's ongoing. So that every year they recruit medical students across the country of color, pair them with myeloma doctors, and then hopefully they'll go on to be myeloma physicians also. The MMRF also has not so much a mentorship program, but has grants for recruitment of students of color into myeloma specifically. And then the American Society of Hematology for years has had various programs starting in high school to recruit hematologists into not just myeloma, but in hematology in toto. So there's a lot of effort going into that. You know, the trick that we have, the big trick is to try to divorce ourselves away from the big institutions and have more myeloma doctors in the field. And because it's a complex field, and to the people in the thumb, to the people in Mississippi, to the people in Arizona, and Nevada would be, you know, key.
Orlando.
Happen here. All right. Well, I thank you so much. We're at the end of our hour. And I thank you so much, Dr. Cole, for being with us today. I thanks again to all of our sponsors that help us bring this discussion to all of you that have joined us today. These discussions have been recorded, and we will be putting them on our curemultiplemyeloma.org website. And just a reminder too of our upcoming events, Wine and Dine in the D on November 6th. Mark your calendars. And also Dr. Cole spoke of Dr. Zonder. He's our next discussion coming up in May, on May 8th. There's 2 in May and 2 in June to close out these discussions for the year. And we'll be here. If you want to attend, just go to our website. And again, thanks so much, Dr. Cole. Um, Thanks for being here. Thanks for all the great questions from those that on the chat. And have a wonderful rest of your day.
Thanks, everybody.